Next, we'll discuss electrolyte disorders, a topic that's extremely high yield on the USMLE Step 2, mainly because of their high prevalence in the clinic and hospital setting. We'll cover hypernatremia, hyponatremia, hyperkalemia, and hypokalemia. Even though it's easy to think of hypernatremia as a problem of too much sodium, it's actually more accurate to think of hypernatremia as a problem of too little water. Some of the processes that can lead to excess loss of free water include sweating, burns, fever, pneumonia, which leads to insensible loss from hyperventilation, diarrhea, and diuretics. Another cause of hypernatremia is a condition called diabetes insipidus. It leads to high urinary volume and water loss because of insufficient or ineffective antidiuretic hormone. The symptoms they may describe in a clinical vignette for a patient with diabetes insipidus include confusion, disorientation, lethargy, and sometimes seizures. As a general rule, sodium disorders cause CNS problems, which is why you see neurologic symptoms as the predominant presenting complaint. If uncorrected, severe hypernatremia causes coma and can lead to irreversible brain damage, which is why it's so important to detect it early. Diabetes insipidus can be further subdivided based on where the problem is in the body. The etiology of central diabetes insipidus is a loss of antidiuretic hormone production, so it can occur with either a problem in the hypothalamus, where the antidiuretic hormone is actually produced, or the posterior pituitary, where the antidiuretic hormone is released from. Lastly, if there is an anatomic disruption between the connecting structures of the hypothalamus and the posterior pituitary, that can also lead to central DI. You might see this in the cause of head trauma or after a neurosurgery. By definition, nephrogenic diabetes insipidus is not a problem with production, but rather an effect on the target organ. So the antidiuretic hormone is present in normal levels in the blood, but isn't able to exert its effect on the kidney. Some etiologies you'll want to be aware of for the USMLE Step 2 for diabetes insipidus that is central in origin are CNS disorders such as stroke, tumor, trauma, hypoxia, and infection. Whereas causes of nephrogenic diabetes insipidus, more often than not, it's going to be a patient who's super therapeutic on lithium. But other etiologies include taking demeclocycline, which blocks the antidiuretic hormone receptor, chronic kidney disease, which renders the kidney unable to respond to antidiuretic hormone normally, hypokalemia, and hypercalcemia. Most causes of hypernatremia are due to losses of fluid, either from the skin or gastrointestinal tract. In cases such as those, if the kidneys are functioning normally, their response is to try to reduce urine volume, thereby preserving circulating blood volume. They do that by concentrating the urine and reabsorbing as much sodium as possible to increase water reabsorption. So, if you're trying to distinguish diabetes insipidus from other causes of hypernatremia, here are some things to look for. In diabetes insipidus, you often see increased urine volume and decreased osmolality. You also see decreased urine sodium. In a nutshell, diabetes insipidus is the presence of high urine volume of very dilute urine, despite dehydration and hyperosmolality of the blood. If you see these findings described in a clinical vignette, they're more likely describing diabetes insipidus. Okay, so back to the question that the USMLE Step 2 loves to ask. What is the best initial test in diagnosing diabetes insipidus? The correct answer is a water deprivation test. And this test is basically just what it sounds like. We place a patient in a hospital room, we don't allow them to drink any water, and we monitor what happens to their urine. If, after depriving the patient of water, they decrease their urine volume and they increase their urine osmolality, that makes the diagnosis of something called psychogenic polydipsia, which is basically a nice way of saying somebody drinks too much water for psychiatric reasons. The problem is not with production or effect of antidiuretic hormone. If, on the other hand, after depriving a patient of water, they continue to have high volume, dilute urine, that makes our diagnosis of diabetes insipidus. So, once we've diagnosed DI, what's the next best test? To figure out whether we're dealing with a central problem or an end organ problem, we do an antidiuretic hormone administration test, which is basically where we give the patient an exogenous dose of antidiuretic hormone. If after we give the patient ADH, their urine volume decreases and urine osmolality increases, we've made the diagnosis of central diabetes insipidus. We've proven by their kidneys' ability to respond normally to antidiuretic hormone that the problem was with production. If, on the other hand, after giving ADH, the patient continues to have high volume dilute urine, we've made the diagnosis of nephrogenic diabetes insipidus. Even with extra ADH given, the kidneys are not able to respond normally. If they ask you on the USMLE Step 2 for the most accurate test in telling central from nephrogenic diabetes insipidus, the correct answer is going to be to measure a serum antidiuretic hormone level. In nephrogenic DI, it's going to be elevated or normal because the brain is producing it in normal amounts, whereas in central DI, it's going to be low because the problem is with production. So in summary, what are some key features of central versus nephrogenic diabetes insipidus? First, which form has symptoms of polyuria and nocturia? Central diabetes insipidus definitely does. So does nephrogenic diabetes insipidus. Both forms of DI are going to experience these symptoms because both of them present with high volume dilute urine, even in the face of water deprivation. So what about urine osmolality and urine sodium? In both central and nephrogenic diabetes insipidus, these are going to be low. Again, because the presenting findings are going to be high volume dilute urine. Which form is going to have a positive water deprivation test? Actually, both of them will. Remember, the water deprivation test was our first step in determining whether somebody has true diabetes insipidus versus psychogenic polydipsia, or just drinking too much water. Now, which form is going to respond to antidiuretic hormone? The central form of diabetes insipidus will have a response to ADH because the problem was with production, whereas nephrogenic diabetes insipidus will not respond to exogenous ADH administration. Finally, what about serum ADH level? Remember, this is our gold standard test in telling whether the diabetes insipidus is central or nephrogenic in origin. Central diabetes insipidus has a low ADH level, whereas nephrogenic diabetes insipidus has a high or normal ADH level. Treatment of hypernatremia depends on the etiology. If you suspect fluid loss based on the history given in the clinical vignette, you have to correct the underlying imbalance. If the history and diagnostic testing describes central diabetes insipidus, the treatment is to replace the deficient antidiuretic hormone. Replacement comes in the form of vasopressin, which is also known as DDAVP. If after diagnostic workup, you determine that the patient has nephrogenic diabetes insipidus, the treatment is a little less straightforward and also a little less effective, unfortunately. The first thing to do is to correct the underlying electrolyte disorders. Often potassium and calcium are deficient in patients with nephrogenic DI, so you have to replace those if you need to. Additionally, you'll want to stop any medications that are associated with causing nephrogenic diabetes insipidus. Again, the most likely offenders that you're likely to see are lithium or dimeclocycline. If all else fails, you can try giving hydrochlorothiazide or NSAIDs for those who still have nephrogenic diabetes insipidus despite these interventions. But really, the best advice for your patient is to have them drink enough water to try to keep up with the urinary fluid loss. Now, if you encounter a patient, either in real life or in the USMLE Step 2, who has very high sodium levels, it's natural to want to give them fluid or perform other interventions to bring down that sodium as quickly as possible. But it's important to remember that there are complications in treating hypernatremia. The most feared one is the development of cerebral edema. This can happen when sodium levels are brought down too rapidly. Presenting symptoms of cerebral edema are worsening confusion and seizures, and this can sometimes be difficult to detect because remember, the symptoms of sodium imbalance often are neurologic in origin as well. Now let's switch gears and talk about hyponatremia. Now remember, just like hypernatremia wasn't a problem of having too much sodium in the body, hyponatremia is not a problem of too little sodium. Rather, it's going to be a problem of increased free water retention by the body. The first thing to do if you're presented with a patient who has low serum sodium is to assess their volume status. If they appear hypervolemic on exam, such as they present with findings of increased lower extremity edema or crackles on pulmonary exam, you'll start thinking about the three main etiologies for hyponatremia with a hypervolemic state. Those three are congestive heart failure, nephrotic syndrome, and cirrhosis. Together, these three make up the famous three OSISes: cirrhosis, nephrosis, and cardiosis. CHF, nephrotic syndrome, and cirrhosis are all situations that lead to decreased intravascular volume. That leads to decreased pressure sensed by the atria and in the carotids. Those pressure receptors sense the decrease in volume and then stimulate antidiuretic production and release from the posterior pituitary. This antidiuretic hormone acts on the kidney to promote free water reabsorption. And even though sodium concentration drops when that happens, it's still more important to maintain vascular volume and organ perfusion. There are also some etiologies that lead to hyponatremia in the face of hypovolemia. These include sweating, burns, fever, pneumonia, diarrhea, and diuretic use. All of these cause hypernatremia as well. However, they can cause hyponatremia if there's a chronic replacement with free water as isotonic fluid is lost by these processes. In addition to conditions that increase antidiuretic hormone production, conditions that lead to a loss of aldosterone can also lead to hyponatremia. The most commonly tested one in this category is Addison's disease. In Addison's disease, there's a loss of adrenal function that leads to a loss of aldosterone production by the cortex. Aldosterone's main job is to cause sodium reabsorption at the level of the distal convoluted tubule. If the body loses aldosterone, it's going to lose its ability to reabsorb sodium. Again, when classifying etiologies of hyponatremia, the most important thing to first assess in your patient is volume status. If you assess your patient and you find that they're neither volume up nor volume down, you'll want to think of some of these causes of euvolemic hyponatremia. The most common causes include something called pseudo-hyponatremia, which is seen in the setting of hyperglycemia. And this happens because when there are very high levels of glucose in the blood, that acts as an osmotic draw. Water will leave the intracellular space and follow the glucose particles into the extracellular space. With increased fluid in the extracellular space, that dilutes the sodium levels that are actually there. So in pseudo-hyponatremia, there's no difference, there's no change in the amount of sodium in the body. It's just that the fluid has shifted from intracellular to extracellular, and it appears that the concentration has gone down. Now there is a formula to correct sodium level for hyperglycemia, and that includes for every 100 milligrams per deciliter of glucose above the normal value, you have a 1.6 milliequivalent per liter decrease in the sodium. The next cause of euvolemic hyponatremia is something we've talked about already, psychogenic polydipsia. That's when a patient, for unknown reasons, ingests massive amounts of free water. The kidney is only able to produce 12 to 24 liters of urine per day, so if you drink more than 12 to 24 liters of water a day, you're going to overwhelm the kidney's ability to excrete water. Next, hypothyroidism. Thyroid hormone is needed to excrete water, so if the thyroid hormone level is low, free water excretion is likewise going to be decreased. And finally, any condition leading to the syndrome of inappropriate ADH secretion can cause euvolemic hyponatremia. In general, any brain disease or lung disease can cause SIADH. Also, certain drugs are associated with SIADH as well. The ones to remember for the USMLE are SSRIs, sulfonylureas, vincristine, cyclophosphamide, or tricyclic antidepressants. Also, a highly testable cause of SIADH is small cell lung carcinoma. This cancer actually produces antidiuretic hormone, so patients with small cell lung carcinoma are going to have high levels of circulating ADH. The presenting symptoms of hyponatremia are entirely neurologic in nature. The ones to look out for are confusion, lethargy, disorientation, seizures, and coma. They sound pretty similar to the symptoms of hypernatremia. The thing also to remember is that these symptoms are totally dependent on how fast the hyponatremia occurs. A sodium level of 120 might be totally asymptomatic in a patient who developed SIADH slowly over time, but a patient who goes from 140 to 130 in a matter of an hour or two can develop life-threatening symptoms really quickly. It's important to recognize SIADH because the treatment of SIADH is very different from other causes of hyponatremia. In the setting of SIADH, actually giving normal saline without a diuretic can worsen the sodium levels. You'll suspect SIADH if these things are described in the clinical vignette: a high urine osmolality, high urine sodium, low uric acid levels and BUN, and the most accurate test in detecting SIADH is to obtain an ADH level and to find that it's high. Urine studies can be particularly helpful in distinguishing SIADH for other causes of hyponatremia that have a normal antidiuretic hormone level. When looking at urine osmolality, if there's a normal amount of ADH in the blood, the urine is going to be very dilute, less than 100 milliosmoles per kg. In contrast, in the setting of SIADH, the urine is going to be very concentrated because there's an inappropriately high amount of antidiuretic hormone leading to the reabsorption of free water, even when it's not physiologically advantageous. Next, you can look at urine sodium. Again, in a hyponatremic patient with normal levels of ADH, we would expect the urine sodium to be low, less than our threshold of 20 milliequivalents per liter. But if there's inappropriately high levels of ADH present, the urine sodium is going to be high, greater than 40 milliequivalents per liter, as the body inappropriately reabsorbs so much free water. When faced with a question on the USMLE Step 2 regarding how to treat hyponatremia, it's important to remember that the type of IV fluid, medication, or other intervention is not going to be based solely on the actual sodium concentration itself. We won't choose our treatment by a number. We're going to choose the treatment or intervention based on the symptoms that the patient is experiencing. So now let's discuss some specific treatment options. If the hyponatremia is mild, the patient may not exhibit any symptoms at all. In this case, if you're just treating an abnormal sodium value on the labs, the management is simply to restrict fluids. However, if the hyponatremia is more moderate in nature, the patient may start to experience some symptoms of minimal confusion. If those are the symptoms, the management is to give normal saline along with a loop diuretic such as furosemide to promote the excretion of free water by the kidney. Now, if the hyponatremia is severe or very sudden in onset, this is where we see the neurologic symptoms such as lethargy, seizures, or ultimately a coma. In this case, the treatment is more aggressive. This is where you'll choose 3% hypertonic saline or ADH antagonists such as conivaptan or tolvaptan. Now, these medications are no joke. You have to give them IV, it has to be in a controlled setting, and there has to be careful monitoring of the patient while these medications are being given. Another ADH antagonist that can be used for more chronic, mild SIADH is dimeclocycline. This is also an ADH antagonist, but it can be given either PO or intranasal, and it blocks the action of ADH at the collecting duct of the kidney tubule. Again, because correcting low sodium too quickly can lead to life-threatening complications, the USMLE test makers often write questions about it. In general, hyponatremia should be corrected at a rate comparable to its onset. In other words, if the hyponatremia occurred very suddenly over the course of a few hours, you may be able to get away with correcting it more quickly. But as a general rule, your goal is to increase the serum sodium by 0.5 to 1 milliequivalent per hour. That works out to about 12 to 24 milliequivalents per day. What happens if you go too quickly? If the sodium level is brought up to normal too rapidly, you can get the feared complication of central pontine myelinolysis. On this MRI, you can see an example of central pontine myelinolysis. In the center of the pons, this white area represents an area of myelin loss as fluid shifts occurred rapidly when hyponatremia was corrected too quickly. Central pontine myelinolysis is an especially feared complication because it's rapid, it's irreversible, and it's often fatal. Switching gears from sodium to potassium, we'll begin our discussion of hyperkalemia. Now, the etiology, complications, and treatment of hyperkalemia is highly tested on the USMLE Step 2 because it's so important to recognize quickly and treat clinically. Hyperkalemia is typically defined as a potassium level greater than 5 milliequivalents per liter. And severe hyperkalemia can stop the heart in seconds if the level of potassium is high enough or rises quickly enough. Potassium chloride is actually an ingredient in the lethal injection used in executions for that exact purpose. If you're faced with a patient with elevated serum potassium, there are three main categories of etiologies to consider. The first one you'll want to rule out is something called pseudo-hyperkalemia. This happens when the blood sample is hemolyzed and the potassium inside the red blood cells spills out into the serum of the sample. It can also be seen in the setting of leukocytosis or thrombocytosis. But the treatment is easy. You repeat the blood sample, preferably without a tourniquet, and run the potassium level again. Now, once you've confirmed that the hyperkalemia is real and not because of a hemolyzed blood sample, there are two main broad categories of why the serum potassium might be high. It might be high because your kidneys aren't excreting enough of it, or it might be high because the potassium is being shifted from inside the cells to outside the cells. So let's talk about decreased excretion first. Some main reasons potassium isn't excreted from the body in the manner that it should be include renal failure, and that could either be acute or chronic in nature. Additionally, anything leading to a low aldosterone state can lead to decreased excretion of potassium. Remember, the main jobs of aldosterone in the kidney are to facilitate the reabsorption of sodium and the excretion of both potassium and protons. So low aldosterone leads to the retention of more potassium than normal. So what can cause low aldosterone? Well, medicines like ACE inhibitors and angiotensin receptor blockers can block the action of aldosterone or block its production. A type 4 renal tubular acidosis is associated with the low aldosterone state. Other drugs can have a low aldosterone state as a side effect. And then we can't forget Addison's disease, where a deficiency in the adrenal itself decreases the amount of aldosterone produced from the adrenal cortex. Now let's talk about reasons that intracellular potassium might be released into the serum in levels greater than normal. The most important way for potassium to get from inside the cells to outside the cells is for those cells to break apart. This can happen in the setting of rhabdomyolysis, tumor lysis syndrome, any setting in which cells in the body are breaking apart and releasing their intracellular contents. Additionally, low insulin state can lead to the increased release of potassium from the inside of the cells to the outside of the cells. Acidosis can likewise lead to a shift from intracellular to extracellular potassium. Medications such as beta blockers, digoxin, and heparin can also lead to a shift of potassium from inside to outside the cells. So why do we care about hyperkalemia? Well, we care about it because potassium in the correct concentration is necessary for normal muscle contraction and cardiac conductance. So what symptoms should you look out for in a patient in whom you suspect hyperkalemia? Unfortunately, they're a little bit nonspecific, but they have to do with problems with muscle contraction. You might see weakness, paralysis, ileus, which is basically the paralysis of gut muscles, and cardiac rhythm disorders. As a general rule, when comparing sodium disorders from potassium disorders, sodium disorders are associated with neurologic symptoms and CNS complications, whereas potassium disorders are more associated with arrhythmias and problems with cardiac conduction difficulties. So back to test day. What is the most urgent test in a patient in whom hyperkalemia is suspected? It's not potassium level. The correct answer is EKG. More important than knowing the exact concentration of potassium in the blood, you'll want to know if your patient is manifesting the cardiac complications that are associated with hyperkalemia. So what might you see on the EKG in someone with very high serum potassium? You might see the peaked T waves, wide QRS complex greater than 120 milliseconds, or a prolonged PR interval greater than 200 milliseconds. On this EKG, we can see all three of those characteristic findings. So once you've determined that your patient has hyperkalemia, what are you going to do to treat them? The treatment depends on a few key factors. First, you're going to want to determine whether or not the hyperkalemia is real, because in the case of pseudohyperkalemia, no specific treatment is needed. You just need to repeat the blood sample, preferably without a tourniquet, and get a more accurate reading for serum potassium. So what about if you determine that the hyperkalemia is real? Remember, our best first test is going to be that EKG. If you see those EKG changes we talked about, those peaked T waves, the widened QRS, the prolonged PR interval, the most vital first intervention is going to be to give a calcium-containing compound. Correct choices could either be calcium chloride or calcium gluconate. And it's important to remember that these calcium-containing agents do nothing to change the serum potassium level, but they're vital because they're going to stabilize the cardiac cell membrane and prevent the development of arrhythmias. Once you've protected your heart, the next interventions are going to be aimed at shifting extracellular potassium back into the cells. The ways we can do that include giving insulin along with glucose to prevent hypoglycemia, or to administer an inhaled beta agonist. Both of these are going to be aimed at facilitating the shifting of potassium from outside the cells back inside the cells. You can consider giving bicarbonate if you think acidosis is the cause of the hyperkalemia, because acidosis causes the shifting of potassium from inside the cells to outside the cells. Making the blood more alkaline can cause the potassium to shift the other way. Finally, if all these interventions are not effective and the EKG changes persist, hemodialysis is the last-ditch effort in treating severe hyperkalemia. So if you don't see EKG changes, then the treatment is going to be a little bit less severe. Your treatments in this case are going to be aimed at getting rid of total body potassium. There are a couple ways to do this. One is to give a medication called K-exolate, which facilitates the excretion of potassium through the GI tract, or you can give loop diuretics such as furosemide to promote the loss of potassium through the urinary tract. So to recap, if you see hyperkalemia in the setting of an abnormal EKG, the next best step is always calcium chloride or calcium gluconate. And remember, the key differences between disorders of sodium and disorders of potassium are that disorders of sodium lead to neurologic symptoms and CNS complications, whereas hyperkalemia leads to muscular symptoms and cardiac complications. Now shifting gears to hypokalemia. The definition of hypokalemia is a serum potassium level less than 3.5 milliequivalents per liter. Remember that the cutoff for hyperkalemia was greater than 5 milliequivalents per liter. And although it can be nice to know these cutoff values, for test day you never need to memorize these because you'll be able to look up the normal reference values for any given electrolyte or other lab. So if you're given a patient with hypokalemia, there are 4 main categories of etiologies. The first and most rare is decreased oral intake of potassium. This is pretty rare because the kidneys are good at decreasing the amount of potassium it excretes based on the amount of potassium taken in the diet. So only in very severe cases of malnutrition will we see hypokalemia solely because of decreased intake. The second category of etiologies for hypokalemia is excess shifting of potassium intracellularly. Things that can cause intracellular shift include alkalosis, increased insulin, beta agonist, and they work to stimulate the sodium-potassium ATPase pump. Do these look familiar? They should, because all of these are agents used in the treatment of hyperkalemia, when the goal is to shift potassium from extracellularly to intracellularly. The third major category of etiologies for hypokalemia include increased renal losses. Things that facilitate increased potassium loss through the kidneys include anything leading to a high aldosterone state. Again, remember the major actions of aldosterone. Aldosterone serves to increase sodium reabsorption, potassium excretion, and proton excretion. So anything leading to high levels of aldosterone will lead to high potassium excretion. So things that can lead to high aldosterone include Conn syndrome, or an aldosterone-producing tumor, low volume leading to a contraction alkalosis, Cushing's syndrome, Bartter syndrome, or excess licorice ingestion. Low levels of magnesium can also lead to hypokalemia, and this is because there are some magnesium-dependent potassium channels in the kidney. When the magnesium is low, these channels open and spill excess potassium into the urine. Also, type 1 and type 2 renal tubular acidoses are associated with hypokalemia. This is in contrast to type 4 RTA, which is associated with hyperkalemia. The fourth and final category of etiologies for hypokalemia is GI losses. And the 3 main ways you can lose potassium through your GI tract are vomiting, diarrhea, or the excessive use of laxatives. Similar to hyperkalemia, hypokalemia often leads to problems with muscle contraction and cardiac conduction, because potassium is essential for the proper function of neuromuscular contraction. So what are the symptoms? A patient with hypokalemia may present with weakness, paralysis, and loss of reflexes. Again, they're not very helpful and they're kind of nonspecific. But it's important to remember that the muscular abnormalities associated with hypokalemia can be so severe that they actually cause rhabdomyolysis. Hypokalemia is also associated with characteristic EKG findings. These include the famous U waves that are the most pathognomonic finding for hypokalemia, but other associated findings include ventricular ectopy, manifest as PVCs or premature ventricular contractions, flattened T waves, and ST depression, which can be confused with ischemia. Again, problems with potassium do not cause neurologic effects, so even very, very low serum potassium levels will not result in seizures. So remember that the treatment of hyperkalemia was kind of complicated and depended on whether or not there were EKG changes present. Hypokalemia is a different story. It's a little bit more straightforward. If the potassium is low, you should replace it. So your two main options for potassium replacement are oral versus IV potassium. Oral potassium replacement is nice because there's no maximum rate. The GI tract isn't able to absorb potassium faster than the kidneys can excrete it. So even if you give a whopping dose of potassium by mouth, you won't cause a hyperkalemia. With IV potassium, it's another story. If you replace potassium too fast through the intravenous route, you can actually provoke a fatal arrhythmia that can lead to death. When giving potassium IV, you have to allow for time for the potassium to equilibrate into the cells, so it really can't be done any faster than about 10 milliequivalents per hour. In a nutshell, with oral potassium replacement, go nuts. You can't give too much, but IV potassium replacement must be done very slowly. Let's apply what we've learned to a clinical vignette. Here we have a patient who's admitted with vomiting and diarrhea from gastroenteritis. His volume status is corrected with IV fluids, and his diarrhea resolves. His pH is 7.40, and his serum bicarbonate has normalized. Despite vigorous oral and IV replacement, his potassium levels have failed to rise. What should you do? Our answer choices here are to consult nephrology, check a magnesium level, check a parathyroid hormone level, check intracellular pH, or to perform a 24-hour urine potassium level. So what's the right answer? What could cause refractory hypokalemia even in the face of vigorous replacement? The most common cause of this is low magnesium. So the correct answer is B, to check a magnesium level. Remember that we said low magnesium can lead to increased urinary losses of potassium. So if magnesium is low, you can replace all the potassium you want. It'll just continue to spill into the urine. The best way to treat this hypokalemia is actually to give magnesium and potassium together. So why are these other answer choices wrong? A is wrong because you really should avoid performing consults on the USMLE Step 2. You're expected to be able to handle everything yourself unless a special procedure is required, like a cardiac catheterization or endoscopy. C is wrong because even though magnesium is needed for parathyroid hormone release, it shouldn't be related to potassium that fails to correct with replacement. Abnormalities in intracellular pH could lead to refractory hypokalemia, but it's by far not the most common cause. Finally, E is a little tricky because in the case of hypomagnesemia, you would see increased potassium on a 24-hour urine sample. However, low magnesium isn't the only cause of increased urinary losses of potassium, so it wouldn't give us the definitive diagnosis. Now let's take a look at our final clinical vignette. Here we have a woman with end-stage renal disease as well as G6P dehydrogenase deficiency. She skips dialysis for a few weeks and then experiences a crush injury during a motor vehicle accident. She's taking dapsone and also has recently begun eating fava beans. What is the most urgent step in the care of this patient? Our answer choices are to initiate dialysis, perform an EKG, to give bicarbonate, to give insulin, to give K-exolate, or to check a urine dipstick CPK levels, or urine myoglobin. So in this clinical vignette, we're basically given every risk factor ever for the development of hyperkalemia. Not only does this lady have kidneys that don't work and she skipped dialysis, but she also has a condition that predisposes her to hemolysis, and she's experienced an injury that's likely to lead to rhabdo. So she has lots of reasons to be hyperkalemic, and what's our first best test in anyone in whom we suspect hyperkalemia? The correct answer is to perform an EKG. It's the most important first step to assess the severity of hyperkalemia and to help guide subsequent treatment. So now that we know what the right answer is, let's take a look at why the wrong answers are wrong. Dialysis may be necessary for this patient, but we have to take a look at the EKG and assess for changes first. Bicarbonate and insulin can both be given in the case of hyperkalemia with EKG changes, but both of these can take 15 to 20 minutes to work in shifting the potassium from outside the cells to inside the cells. K-exolate is even slower. It can take hours to work to bind up the potassium and to excrete it via the GI system. F, G, and H, all of these are wrong because they are tests that can confirm either hemolysis or rhabdomyolysis, but while they might diagnose the reason for the hyperkalemia, they do nothing to address the life-threatening complications. So remember, anytime you're given a clinical vignette in which you suspect hyperkalemia, the best first test is going to be an EKG. And that concludes this section.